UHA Cleveland is an organization of undergraduate students at Case Western Reserve University that aims to address various aspects of healthcare access and health literacy. UHA Cleveland works to promote healthy lifestyles to those in the Cleveland area by planning and facilitating various initiatives that address healthcare access and health literacy while collaborating amongst like-minded organizations. In doing so, UHA Cleveland hopes to engage students in efforts to help alleviate health disparities in the greater Cleveland community. If you're interested in our work, please visit our website posted in the Zoom chat. Today's roundtable panel aims to educate and spark conversations towards diminishing racial, ethnic, and socioeconomic health disparities in the Cleveland area. We believe these issues have risen to even greater significance due to the impacts of COVID-19 over the past year. Cleveland is one of the many cities that has always struggled with health disparities, and COVID-19 has both highlighted and exacerbated these longstanding problems. Joining us today are two experts that come from extensive backgrounds in healthcare, education, and activism, Ms. Yvonka Hall and Dr. Edgar Jackson. We had planned to include one other expert, Dr. Scott Frank, who is a public health and family medicine educator, researcher, and practitioner. However, due to unanticipated events, Dr. Frank unfortunately will not be joining us this afternoon. So I'd like to begin with a brief description of the panelists' backgrounds, starting with Ms. Hall. Ms. Hall is the executive director of the Northeast Ohio Black Health Coalition. Ms. Hall received a Master of Public Administration from Texas Southern University and a Bachelor of Arts from Notre Dame College. Ms. Hall is a nationally recognized congressional award-winning health disparities expert and a Robert Wood Johnson Fellow. She speaks all over the country about effectively engaging the African-American community and the art of community engagement. She is an activist who has been deeply impassioned and involved in local and national social justice activities for almost 3 decades. Dr. Edgar Jackson is a nationally renowned physician, scholar, and advocate of eliminating healthcare disparities among minority populations. Dr. Jackson received both his Bachelor of Arts in Chemistry and Doctor of Medicine degrees from Case Western Reserve University. Through Dr. Jackson's work as a private practice physician, hospital system executive, academic, and community leader, he founded, co-founded, and led several initiatives that have positively impacted community health care delivery. On behalf of UHA and Case Western Reserve University, I'd like to thank the speakers for their time and insight into these important issues. Under the broader topic of racial, ethnic, and socioeconomic healthcare disparities in light of the COVID-19 pandemic, today's panel will focus on 3 main subtopics in the following order: mental health, then misinformation, and lastly, institutional responsibilities. Lastly, before we begin our panel, I'd like to offer the audience the opportunity to post questions in the Zoom chat throughout the event. We may present some of these questions to experts at the end of the event. So without further delay, let's begin. All right, so we are all aware of some of the impacts of COVID-19 on mental health. And aside from raw anxiety regarding the danger of the virus, many have been afflicted with mental illnesses related to social isolation. I'd like to begin the first question that I'm sure both of you can speak equally well to. So the question is, and feel free to chime in, either of you. So the question is, have you directly witnessed the impacts of the pandemic on mental health and of those around you at the workplace? So feel free, either of you.
Hi, so I'm Yvonka Hall. So I am not at a workplace, so I am at a home office, but I do have a staff. And I think that, part of what we have witnessed is that by the large majority of us being at home and being able to watch television and see some of the news reels every single day about policing in America and police brutality. When we talk about COVID, what it has allowed is us to see things in a different context. And so people who normally are able to tune out because they're at work from 9 to 5 or 8 to 4:30, or they're working first or second or third shift, aren't able to see a lot of things that are going on in the news. So sometimes it doesn't play into your psyche. But for us, for over a year, well over a year, that has been our day in and day out. So that has definitely played a large role in how people are reacting to COVID, the things that we see, the things that we normally don't see. or here. I know that last week when we had the verdict, a lot of our staff were just physically, on our call crying. And so we don't know if it's not related to the fact that they've had COVID, because they haven't, but it's related to the fact of what COVID has been able to expose us to. And it's a whole world, a different world outside of what we normally see when we're in office settings. And so we get a lot of calls, my organization, because of what's going on. And one of those things has been us creating a support group, 3 support groups for African Americans that have experienced COVID. They either have tested positive for COVID, they are long haulers, or they have had death as a direct result of COVID. So COVID has done, when we always talk about this glaring light that COVID has shed, it has definitely shed a glaring light on the impact of mental illness and mental instability in the African American community.
Those are great comments. Thank you so much. And Dr. Jackson, I'd like you to comment as well.
Yes, my wife and daughter have been working at home for the last year, and many other younger colleagues that I interact with have similarly been working from home, and they've experienced sort of sense of isolation, mood changes, weight gain. Some of my colleagues, more alcohol consumption. So a lot of the negative aspects, absent being affected by the virus directly, have been issues like that. And of course, the issues of domestic violence and all of those things have occurred as well. But certainly in my group that I associate with a lot, it's been weight gain, mental status changes, lack of exercise, things like that.
Right. And may I ask, is it more because of just the fear of the virus, or is it more because they're socially isolated and they can't interact with people like they normally would?
I think that from the ones I've observed, it's more social isolation. And many of them, their coworkers have had the same experience. They've all put on 15 to 20 pounds. And they've all drink a little bit more than they would if they were out and active. Right. And they all have periods of sadness as well, and depression.
Right. Well, thank you for sharing your experience, both of you. And I'd like to ask as well, these people that you've been sharing stories about, were they able to seek help, and if so, how were they able to do that?
So for us, one of the things, so I am a COVID survivor. I am a long hauler. And so one of the things that I looked at is the fact that we didn't have support groups around COVID for African Americans. And so that was one of the things that my organization wanted to make sure that we reached out so that people would know that they could have culturally competent care. And be able to talk about some of the things that maybe things that are different culturally, because my organization focuses on African Americans. So I have to be real and let you know that we're receiving things in a different way. Like even with mental illness, like we receive diagnosis in a different way than other communities, or lack of diagnosis than other communities. And so it's important for us to understand like how all of those things kind of feed into, whether people will reach out for support, because they may not reach out to traditional agencies, but they may call me because, oh, well, you're doing health. So we're going to call you, and they just think it's mental health. But now the great opportunity that we have is that we do have a trained mental health therapist that's on the staff that's able to, talk with them and talk to them in the way that they can kind of understand, because, one of the things around COVID is like your loss of taste. And so things that you used to like, you may not like anymore. Or we talked about the weight gain, or things that you shouldn't have that you have in overabundance. Um, like you don't go just buy one bottle of wine, you buy enough to make sure you have enough, for the whole week. Or, whether you're going to get things, you're going out to buy things in mass quantity that you normally we wouldn't. And so having supports in place to talk to people that aren't used to talking to therapists for me was very important. And that was important for my organization as well.
I think another devastating thing, in addition to the virus, has been the constant, repetitive, negative interactions between police and Black, especially Black males. It's been devastating to be continually reminded of the vulnerability, especially of Black men, to police. And that, certainly for me, has been a very difficult thing to deal with.
And now that you say that, Dr. Jackson, I think the
Yeah.
the other thing that's important when we're talking about that around these interactions, and the mental health issues that we see in the community as a direct result. I mean, we already had people who face trauma in the community on a daily basis, but to face trauma from the people that are there to protect you, that's a whole different kind of way for you to mindset, for you to click into the fact that people who are here that are supposed to be protecting me are actually a danger to me. And so we know that like young people who have been in foster care are more likely to have mental health issues. But they're also more likely like to have interactions with the police as a direct result of them having homeless issues. And the African American men are 21 times more likely to be killed by the police. And so for us, we need to make sure that we're putting all of these things into the scope around mental illness because, it's like not this one dimensional approach. I think that we always try to take to do these takes on what mental illness is. Mental illness is different for communities that are traumatized because they may not even understand that what they're going through is mental because they have gone through trauma throughout their entire life. And I'm sure that, Dr. Jackson being a medical doctor, and I'm not, that he's seeing things with patients that come into him that would be totally different than what I would see in the setting that I have, but I know that, my families are disproportionately impacted because we've been sending out food to families since last March. We have sent out over 70,000 meals from our house where we actually have people drive those meals to families. And I've had families call me at 2 o'clock in the morning. Their kids have been murdered. So when I had a parent call me at 2:30 in the morning and say, I want you to can you pray for me? Because my son was just killed. I mean, can you understand the trauma of a mother? That in the middle of a pandemic, your baby is gone. And now they're saying, okay, well, only one person can come into the hospital and say their goodbyes to him, or only one person can see him. Like we're like, I call it the onion, is that we have a pandemic within a pandemic within a pandemic in the African American community. And it's because, in the middle, we already had trauma. And so now we're overlaying this trauma with all of these other things that are going on.
Right. I'm so grateful that we're able to talk about these disparities here because to the average person, they might just think, oh, well, it's the social isolation, or maybe it's the anxiety about the virus. But there are so many other factors that play into different racial communities. So thank you both for elaborating on that, and feel free to continue talking about those differences throughout this discussion because that is a major focus here. So thank you both very much.
The one comment I'd like to add on this area is that I think the greatest contribution to equity in interacting with the police is the camera. I'm so thankful that we have the cameras because this has been going on throughout my life and before. But now we can capture it on camera. I mean, the police report initially, for example, with George Floyd was just a typical, he put up resistance and we had to arrest him and bring him in. And then you look at the film and the film has been a great friend.
Yeah,
Okay.
I also, the reason that the reason I agreed to speak today is part of this whole mental health issue and how it impacts the community. Um, because I don't agree to speak at a lot of things. I just don't. Um, but in 19 so on May the 26th, 1975, my uncle's best friend was murdered by the police in his kitchen. He was 19 years old, shot in the back. There was no video cameras. Um, and no one was ever held accountable for his death. So people ask me all the time, why am I why do I push the whole thing around policing and what it does to people? So my mom was murdered the year before. So my mom was murdered by my father in front of myself and my younger brothers. My father had a mental health issue, right? So he had schizophrenia. So my uncle, his best friend was murdered the following year. So all of that, the two deaths, drove my uncle into schizophrenia. And so my uncle has been in a world of his own since 1975. And as a direct result of COVID, because he was in his world of his own, when we're asking him about the pain that he was going through, like he said, my arm hurts, but he never told us the extent of his arm hurting because of the mental incapacity. And so he had to have his arm amputated. One day he said, my arm hurts. The next day, I looked at his hand. I said, your hand is white. You're not getting oxygen. We need to get you to the hospital. I'm not going. I'm not going. Um, and then the next day, his hand was black. Gangrene has set in, and it has started to look mummified. He's 66 years old. He has had to deal with mental health issues his whole life, undiagnosed until 2 weeks ago.
Wow.
Undiagnosed. And so we have to think about what trauma does to people and what it does not just to the people who are hurt. So not just to the fact that George Floyd is dead, but to the fact of that his family has to live. Like, what has it done to them? What has happened to his daughter, his brothers? Like, just understanding that you have lost someone that is a connection to you, someone that you love and that you cannot bring back. And so for me, that is why we have to talk about mental health in a whole different context when we're talking about Black folks.
Absolutely. Absolutely. Thank you. This has been great. Thank you for introducing the mental health topic. And so I'd like to kind of move on and start talking about some of the different factors that are causing disparities in communities and such. So anyways, we're going to start talking about the root causes of health disparities, if that's okay. And so my first question, I'd like to start with Ms. Hall. The question is, what socioeconomic factors contribute to disparities in mental health communities? Why are these contributors, and what puts these communities at greater risk? So this is really just an expansion of what we've been talking about, but feel free to comment some more.
Social economics. We're talking about everything. So we do know this. African Americans have been plagued with persistent race-based disparities that have existed for centuries. This has impacted their health compared to their white counterparts and other people as a whole. So regardless of whether you're talking about education, employment, housing, or health, like all those things impact economics. And so for the African American community, that's been disproportionately plagued by race-based policies and structural deficits, racism within all of these systems, then we definitely have to understand how those play into economics or lack thereof. We talked about essential workers, over the pandemic, and the fact that that we had people who were billionaires who were mad about people collecting unemployment and saying, hey, now we can't get people to come back to work. And I'm like, well, pay them. Pay them. You know what? We really need a universal wage in the United States. Dr. King talked about it a long time ago, but pay them a living wage. And it's not that people don't want to come back to work. It may be some other issues that have gone on with them because of what's going on globally and in their world. But the other thing is, if I'm making $7.25 an hour, and I know that I'm at risk for COVID, then I'm less likely to come in and be put by myself or my family members at risk for COVID when I already have pre-existing conditions. So when we talk about economics and the role that economics plays within the health status of African Americans, we definitely have to look at our education, employment, housing, and health policies, and know that all of those things are underlying factors for the collision course that many African Americans go on.
Absolutely. And Dr. Jackson, could you please comment on the same question?
Can you repeat it?
Yes, absolutely.
Okay, thanks.
Yeah, and feel free to expand on anything Ms. Hall said as well.
Okay.
But the question is, what socioeconomic factors contribute to disparities in mental health in communities? Why are these factors? And what puts these communities at greater risk?
The socioeconomic factor is a huge one. And I think it's really the foundation to a lot of the disparities is the lack of money. When you look at the relative wealth of Black families compared to white families in this country, our relative wealth, and Yvonka, please correct me anytime, because I'm not so familiar with some of the percentages, but it's something like 10 cents or 8 cents on a dollar. Wealth in the Black community compared to the white community. Educational levels are also much less. It's much more difficult for families, poor families, to get their kids to college. So much so that in my own family, my father, who's never went to school a day in his life and was a laborer, struggled to just pay the rent and the utilities for his 5 kids and wife. And that's duplicated around the nation. So that the relative disparity in money, I think, is a foundation to a lot of the other disparities. And when you're thinking, I don't know how familiar you are with redlining. Have you heard of that, Reese?
Yes, I have heard of it.
I'm familiar with it?
I'm familiar. I'm sure both of you know a lot more about it than me, but I learned about it in high school, yes. Yeah,
well, my view of the redlining is, for example, in Cleveland, in the 40s, when soldiers were getting out of the war, the government put money into housing, hopefully to take care of its veterans. The banks decided that they would direct loans for purchasing homes in the various areas. And for Blacks, they would only give a loan if you lived within a certain area. Whites would get the money to live wherever they wanted, but the inner city areas is where we can find a red line, the area where Blacks could get a loan to buy a home. The relative value of that over the last 60 years is enormous. So issues like that, where there's been structural racism in virtually every institution, that's caused the condition we are in. And it really burns me emotionally when then we are criticized for being in the situation we're in. We have to be avoided because we're poor, because they're crying, because of sickness or whatever, when the conditions were set to put us in this position. But that's what redlining is. So with that, socioeconomic disparity was consciously created. And it's hard to dig out of a hole when you don't have help.
Great,
and definitely not even dig out of a hole, but it's like when we talked about the mental health status, all of this feeds into that, because social economic status is linked to to mental health. I mean, it's definitely linked to mental health. People who are impoverished, who are homeless, who are incarcerated, victims of domestic violence, like my mom, or people who have substance abuse problems, are at a higher risk of poor mental health. And then we didn't even talk about the little housing piece. The fact that if you are discriminated against and now you're subjugated to these housing rules, and now you're in houses that now, all of our houses, 90% of them in Cleveland were built before 1978. So they have lead in them. And now we're talking about people who don't have money to fix up their homes, and they have children. And then the impact of lead poisoning, the lifelong impact of lead poisoning on children, and so that's a whole nother thing that leads into what we're talking around economics, because if you're not able to learn and you're not able to do the things that you need to do, how are you able to ever establish yourself in a world market that says, unless you have some money, unless you're not able to compete? And so we already start off with a deficit, particularly for African babies. When we're born, we come into this world with a deficit. And so for us, we're the only community that has to struggle like we do. Like, we always have to prove that that there is a value to us from the very beginning. And then the education systems. So we have educational systems in our communities that aren't educating our children. And so, we do know that one of the ways that we can help to get people out of poverty is through education. And so when you have education centers that don't provide them the things that they need in order for them to compete with other people across the globe, we're gonna always be in a deficit. So we really have to look at policies and how policies play out in our communities, and the role of our policymakers and the role of our professionals in challenging our policymakers to address the issues that disproportionately impact the economics of the African American community. Like for us, we're talking about this whole caste system around economics. White men on top, white women, Black people at the bottom, Black men and then Black women, that still don't make their whole dollar. And so for me, it's like, if you want to fix this, give me my whole dollar. Like, give me what I'm worth. Give me what everybody else gets. Like, I should not get a lower piece of a different cut of the pie because of what racism has allotted to in the United States. And so that's a whole nother conversation. But yeah, we got some stuff to fix.
Yeah, but I am much more optimistic with the Biden-Harris plans, and they appear to be coming at the problem with more understanding and compassion. And I think not only when you look at total numbers, there are more poor whites in this country than poor Blacks, but the poverty or socioeconomic status dictates really everything else.
Absolutely. So thank you so much. I think what I'm taking is that there have been all these inequalities over time. I appreciate the history lesson too. And these have all added up to this really awful situation that we have today. And that sort of circles back to mental health. Is that something I guess everyone's in agreement on?
Yes.
Yeah.
All right. Yeah. I think it's much more environmental than genetics.
Absolutely. Thank you both. So I'd like to finish up the mental health section with just one more question. And so I think this is important. I want to continue on the route we've been going on, and I'd like you to touch on some of the resources that people of varying social strata have access to. So Dr. Jackson, due to your extensive background in medicine, I'd like to begin with you on this question. And the question is, what are some of the discrete mental health resources accessible to Cleveland residents of varying economic and racial backgrounds?
Mental health resources are very, very scarce, markedly underfunded, And unfortunately, when there have been studies to show what works, the money has been limited to allow it to really happen. And in fact, it's worse now than it was when I was in training back 50 years ago. 50 years ago, we had a mental hospital. We had physicians could get paid for seeing the patient. Psychiatrists could get paid, psychologists. And now it's almost the game to try to figure out how to bill to make enough money to pay your overhead and provide the services that are needed. So I think a big issue in mental health has been the lack of funding from the federal level and private insurance carriers to providers to provide the services needed. Does that approach the question that you're raising, or would you?
Absolutely, yes. And of course, we know from this discussion and even beforehand that for people of lower socioeconomic groups, the resources are lacking for sure. And our goal at UHA is to try and bring those communities up, try and provide more resources to them. So, if you'd like to chime in on, what organizations can do, the government and smaller groups like UHA, what we can do to help bring resources to some of these people.
Can I say something on this? I think so. For me, every time I do a presentation, I always have to talk about the whole kind of historical piece because I have a degree in history and political science. But one of the things that we do know that there are only two times that the health status of African Americans changed in the United States, and one of them was the Freedmen's Bureau, and the Freedmen's Bureau brought with it medical centers. For African Americans that saved them from extinction. The second time was the Civil Rights Act. The Civil Rights Act allowed integration of hospital services, and it also brought with it community health centers, which help people have community centers with people who look like them in those centers, heading those centers. So that changed the status of African Americans. When those centers started to be on the decline around funding was in the 80s. And in the 80s, the status of African Americans started to change. So the health statuses that we had gained and worked so hard to gain, we started to lose. And as we know that since 2016, we've lost 3 years of life. So our life expectancy has now went from 75 to 72 years in the African American community. So what I will tell you is that the African American community is the most overstudied and under-resourced community in the world. So we are the most overstudied. We got academics, in every edifice of our community doing all types of studies on everything that, like, why are y'all so happy when you don't have nothing? But when we talk about resources and what resources we need, if it's mental health resources and capacity, one of them is we need some Black psychiatrists. We need some Black psychologists. We have very few Black psychiatrists in the United States. African American men as psychiatrists, like we need to start training up our young people in elementary school to become the doctors that we need in our communities. We need medical professionals, but we need mental health professionals that look like us, because we do know that if people have people in front of them that are serving them that look like them, their outcomes are better. And so for us, the reason that we saw better outcomes in those two periods of time, right, Reconstruction and during the Civil Rights era, is because we started to develop people who look like us into those communities that needed them most. So we need to go back to what works. Because for Black people, the historical is the imperative. The historical that we have around what happened in our community is what will take us into the future. We need to build young people. We need to build their minds when they're young and teach them not how to take a test, but how to make sure that they're learning something that they can be useful for in the future. We have lots of young people that have the minds to be great scientists, to be great doctors, to be great legislators, but to be psychiatrists and psychologists and therapists, people that our community needs in order for them to be able to talk about the historical trauma that they're going through. We talk about historical trauma with people who have been through the Holocaust all the time. Actually, we talk about people who haven't been through the Holocaust, and we talk about the historical trauma. We talk about the fact that trauma is something that is now in your DNA. Once your family has experienced trauma, it is now part of you. And so you cannot tell me that African Americans that have been subjected to the things that we have been subjected to since we were kidnapped from our homelands don't have the same kind of trauma in our DNA as people who have experienced the Holocaust. We experienced the Holocaust. We experienced a different kind of Holocaust for hundreds of years. And so we definitely have to talk about how we can get more trained individuals in our community to help change the conditions of our communities.
Absolutely.
Another factor, I think, in the paucity of mental health professionals is simply money. You cannot provide an hour service for a patient and get paid, say, $15 or $20. When if you be going to ear, nose, and throat, you don't have to be in heart or neurosurgery and earn $1,000 in an hour or $500 in an hour. And the primary care doctor or the psychologist or psychiatrist get paid, if you give ample time to each patient, say $100. The economics drives all of this. And there are many medical students who enter medical school with the full desire to serve, want to be primary care doctors, accessible doctors. And when they get in the field in medical school, begin to see the difference in lifestyle of the surgeons, especially the brain surgeon, the heart surgeon, and other surgeons, versus the primary care doctor. You can understand why primary care is difficult to feel, and why it's difficult to get many doctors to go into psychiatry or pediatric psychiatry, for example, children's psychiatry, because there's just not comparable pay. So it has to be something done to create a more level playing field for the primary care physicians and those who are available to their patients around the clock and all of that. Absent that, we're going to keep getting this sort of skewed production of doctors with very few primary care doctors where they're needed the most.
Absolutely. So thank you. It sounds like then what you're saying is, I think both of you agree, there's a huge just lack of funding. I think the key thing is we need to get more money into these communities. But then also, I think you both touched on the topic of diversity in workplace and in training, of course. Ms. Hall, you talked about, teaching people to become psychiatrists from an early age. I think that's really important too. And so that's something I didn't even think about, honestly, when I was writing these questions was, diversity. I knew there was a lack of funding and that was a primary cause, but of course, we need to make sure we're increasing diversity in some of these fields of study. So thank you both very much. Mm-hmm. And if you don't have any more comments on mental health, I'd like to move on to the next section, which kind of flows from this, I think, but also is deeply related to the topic of COVID-19 and some of the health disparities. So anyways, I think we've had a lot of great insights and feel free to, of course, to connect back to some of the comments made in the past subtopic, of course. So we're all aware of some of the impacts COVID-19 has had on, say, mental health. But now I want to discuss a topic of maybe greater notability ever since the vaccine was rolled out just a couple months ago. So the spread of misinformation has been a major issue throughout this pandemic, as we all know. And there's currently much debate revolving around how this can be combated. So Ms. Hall, I'd like to start with you on this first question on misinformation. And my question is, what is the historical context behind the prominent logical fallacies for medical stigma and vaccine hesitancy in Cleveland?
So, one of the things that I talked about a few weeks ago was there's a such thing around experimentation and vaccine hesitancy. So those are separate concepts that seem to have gotten rolled into one, particularly for African Americans, because we have um, been part of a large number of experiments with the United States government. And so we have this whole historical trauma that has disproportionately impacted the African American community. And then we tie it into this vaccine hesitancy because, we always want to roll everything back to, well, African Americans in Tuskegee. And so part of it is being able to talk to people about the fact that this is um that we have to have a way in order for us to get the vaccine to everybody. That this is just a vaccine for African Americans. This is a vaccine to make sure that we can all get back to doing some of the things the way we used to. And I think that that's one of the things that we haven't talked about enough. I think people jumped right into the boat when they started talking about um, well, African Americans are, they're not going to participate in this because of Tuskegee. And so they came out with this whole thing around we're not going to participate because of Tuskegee, but failed to talk about the benefits to everybody. That this isn't just a vaccine that was just created for Black people. This is a vaccine that's created for all people. So I think that that's the hesitancy is in the fact that we have not given people the information that they need in order for them to understand why it's important for them to be vaccinated.
Excellent, thank you.
Mhm.
And Dr. Jackson, your thoughts on some of the misinformation and vaccine hesitancy?
Well, there is a lot of suspicion, I think, in all populations. One of the big problems was the name of the effort to create the vaccine, Warp Speed. It scared off a lot of people because they thought maybe some corners were cut and you didn't really have a sound basis for the vaccine. People didn't know that the science behind the vaccine had been going on for over a decade. And so the Warp Speed did help cut through administrative hurdles, but it didn't alter the scientific basis of the vaccine. But I think that stuck with a lot in the population. And as far as minorities are concerned, the foundation for suspiciousness goes back to slavery, when many things were done to us medically as well. The great father of OBGYN, for example.
J. Marion Sims.
Yeah, operated on slaves without anesthesia, perfected techniques that he then could use with anesthesia on whites. The Tuskegee we've mentioned, just a whole host of reasons why minorities may not trust immediately. One of the things that I think has helped is there's been a great push by minority leaders around the nation and local leaders trying to inform the Black community, because we have learned not to trust the majority when it comes to saving us, because we don't have any example of that happening. So the trusted Black voices has been very helpful nationally and locally. In Cleveland, for example, we had the combined minority physicians, Black pastors, and leaders of the hospital systems trying to come out with a unified voice that there's sound science behind the vaccines. and that they don't do a lot of the things that are rumored in the community, like alter your DNA and things like that. But I guess that's my overall view, that there's a good reason why minority populations don't trust what comes out of medicine.
And I really do think that we have to look at it and say, who do Black people trust? Because even the people who other folks look at as the most trusted authority may not be the trusted authority to the community.
Absolutely.
And
Right.
so, you know, um, so those things are important. And so we have to look at, who's the messenger, and what message are they trying to get across, and then are people receptive to that message? Because we have sat on these different committees talking about the impact of COVID on the African American community, and talking about 6 months ago, talking about going door to door. Look, we need to change strategy. Strategy needs to take place in the neighborhood, and then we turn around and it's like the Woolsey Center is not the neighborhood. Whose neighborhood is it? It's not the community who really needs the help. It's not their neighborhood. So you're not getting it. So no matter, and I think for us that no matter what we say, people still insist on doing it their way, even when we're telling you your way is not the way that's going to work in our community. And so when people say, well, what's my best way of getting the African American community to listen, and I say, and they say, well, we want to talk about bail reform, but nobody wants to tell their stories. And I'm like, okay, well, who wants to tell you about the saddest moment in their life? Like, who wants to start the chapter of their book on the saddest thing? you know and so if you want to go talk to somebody, you talk to them about something else, and work your way around to the front door. So sometimes you got to go through the back to the back door in order for you to get to the front room. And so we just have to understand that African Americans receive their information in a whole different way than other folks, and that we have to make sure that the people who are the messengers for those communities that need a message. So we can't just say we're going to have this one size fits all approach, and that means that's the approach for everybody, because it just doesn't work that way.
So it sounds like there's been all of these historical events over the past, well, ever since the nation's founding, right? But they've all added up to this horrible situation, and that's caused us to require different solutions, I guess, toward different groups of people, right? In order to get out trustworthy information, because it makes sense that some groups would not trust the government, for example, if they have no reason to trust them due to past events. So of course, Dr. Jackson, you've mentioned things like changing the language. For example, the term Operation Warp Speed could come off as concerning to some people, absolutely. Are there any other mechanisms that could sort of help people of certain groups who maybe not be as trusting of government institutions and such? How can we help these people trust things like the vaccine, I guess, is my question.
I don't know. I'm very impressed with the fact that in the most recent surveys, the greatest group of vaccine hesitancy individuals are Republicans, Republican males, the white evangelicals, Christians. So it's a lot like Yvonka said. It's not a one thing fits all, because the challenges are different with different groups. In the Black community, I think the challenge is finding the trusted voice that works for the target group you're trying to get to. Certainly pastors are very important. And practicing physicians have a lot of influence with their patients. But you have to look for that trusted voice for that target group.
Absolutely. So it sounds
And
like
activists, activists. So
Yes.
activists may not be the people that are at church. So, talking to our activist groups and saying, you're able to get out things that I'm not able to get out.
Yeah.
And making sure that we're, not only utilizing their services, but I think this is the thing. I had a person who had a whole committee of folks that were getting paid. They called me for me to do something volunteer. And I said, okay, so if you're getting paid, why am I volunteering? And so we also have to look at this equity piece around COVID, is that these dollars have come down around how do we address this issue in the community, in order to address marketing and communications and research. But when you look at where the dollars are going, they're not going to the community that's most impacted. And so if African Americans are 25% more likely to be impacted, well, 2.9% of the people who have African Americans are 2.9% more likely to have COVID and 1.9% more likely to die from COVID. And so, if we're looking at these quarter of African Americans who have lost their lives as a direct result of COVID, what kind of message is going out to their families? What kind of message is it going out to their families? Like, we need to understand that, we got this, you got to do this delicate balance on making sure that we're getting people to where they need to be. Like I told you, when we started off, I said, my family was impacted by COVID. And so just that simple fact alone, I said, well, my voice, because this is day 77. 75 days ago, I was checking out of here. Like, I was one of the ones that was dying, and I had to take a drug in order for me to live. So if I had not taken that drug, I would not be here. And so I had to demand a drug in order for me to live. Then I looked at the drug and realized that it wasn't even marketed to me. It was marketed to rural America. That a company put out 300,000 units of belantamab and put it out into Eli Lilly, put it out to rural America. And so I'm like, okay, well, if urban America is disproportionately being impacted, can we get the same drug too? Why did I have to demand something in order for me to live, something that was available? And so I think that when we talk about hesitancy and when we talk about distrust, I mean, do you think that people aren't going to look at this years later and say, we could have saved all of these lives? I've lost 35 friends that graduated between 1985 and 1986 to COVID. 35 friends to COVID graduated 1985, 1986. I don't consider myself old, but they're dead. They're dead because they couldn't fight for the drug that I fought for because they didn't even know it existed. And so for me, when I found out it existed, you know what I did? Put it on Facebook. I put it on there and told everybody to share it. Look, see, this is the drug that will save you. If you have COVID between day 2 and day 10, before you get sick and have to be hospitalized, you go there and you tell them to give you this drug. And if they don't give it to you, you call me and I will call the news. People started getting the drug all over the United States. That is crazy. Mm-hmm. Nobody should have to demand a drug that's available for them to live. And so when we talk about this, hesitancy, vaccine hesitancy, we have to talk about the racism that is still existing, even though we have said COVID has shown this glaring light on the racism of the United States. And yet we still continue to be racist because we are a country that is founded on racism. Like, racism will disappear when it is no longer profitable and psychologically useful, according to Toni Morrison. That is what she said. This is when racism will disappear. And so we have to make sure that we're talking about the role that racism is playing in this whole entire thing around vaccine hesitancy and around historical experimentation and what's going on with Black folks.
Yeah, the one thing I've observed over the years is that, trust, the trusted person is someone you know. And that's whether you're a practitioner in the community. I've seen it in the fairly qualified health centers where multiracial practitioners go and practice in a community and they stay in the community. And it takes several years of staying there for the community to begin to believe that you're going to stay, that you're going to last, that it's not a transient presence. And over time, you build trust. But it takes time. takes time.
Right. Right. Thank you so much. And Ms. Hall, I think you made some great points too about distribution of resources. For example, they're just not being distributed the correct way. Even if they're existent, they're just not getting out to the right places. And then you also mentioned too how important communication is really in some of these communities. We just need to let people know that there are these resources and these drugs that exist. And that's something I want to ask you both about as well. So many of us at Case Western, we have smartphones, we have access to the internet, we've got computers, we have everything, every way possible to get on the internet, right? And we have as much information as we'd like. But we know this might not necessarily be true for people living in underprivileged communities, of course, like a lot of the communities contiguous to Case Western. So I'll open this up to either of you. Feel free to chime in. The question is, what educational or informational sharing platforms should nonprofits and government entities be utilizing to inform underprivileged people?
Mm-hmm.
What should they be utilizing for people that don't have access to Wi-Fi or the World Wide Web?
Yes, exactly. Because we know that some people may not have that access. So how do we communicate to these people?
I always talk about going back to basics, because the other thing too is that everybody don't have a phone. And for poorer communities, they may have they call them Obama phones, but they're minute phones. And so what they don't have is enough minutes to just be sitting there waiting for somebody on the other end to answer a phone. But I think, one of the things that they used to do in old campaigns, and Dr. Jackson, tell me if I'm wrong, in old political campaigns back in the day, they would come through the neighborhood with a bullhorn on their car, and they would go
I've done
through
it.
the neighborhood, and I've done it too.
You've done it.
And they would go through the neighborhood and blast, continually. It would be like they would go through the neighborhood all day, with the same message. So you got this, you hear the hook, you hear the message. And so sooner or later, we know if we hear it 7 times, we got it. So if you come through a neighborhood that is not being tested and you let them know, like, testing is going to be here, and you keep coming through all day, guess what? At the end of the day, everybody in the neighborhood knows testing. Where is it available? At Affinity Baptist Church. That's where testing is available at. Like, because they've heard that message so much that they had to tell other people, like, do you know that there's been a car coming through the neighborhood all day long blasting the same message? Well, what they saying? Oh, they talking about getting tested. Well, okay, tested for what? So they have pushed your message on to the masses. So even the people who didn't hear it will now hear it as they're talking to their friends, or at the grocery store, or at the laundromat. Like, if they didn't get the message, somebody's going to give it to them. And so for us, we have to figure out a way to get back to basics, because we know that there was something in the water that worked back then, because if it didn't, we wouldn't be here now. And so we have to use those same technologies that we looked at as being, that was ultra technology back then, for you to have a thing on your car and be able to go through the neighborhood. And so for now, we just look at, you can go rent it for $50 and go ride through the neighborhood all day. And so we have to look at ways where we can reach people where they are. And if they're not on the World Wide Web, if they're not on Facebook, if they're not on Twitter, if they're not on, any of those kind of things, we have to figure out a way to get back to what worked for us in the past. And that was one of the things that really worked.
Great, thank you. And Dr. Jackson, would you like to comment on some of the ways we can get this information out into the communities that don't necessarily have access to internet and cell phones and such?
No, I'm reminded of the bullhorn, which really was quite effective, and also remember the joy as a medical student going through the community. Today is election day. Now is the time to vote. And you keep doing that all over various neighborhoods, and that did work. I don't know any more direct way other than through the trusted voices of pastors, the politicians for the area, the ward leaders for the area, people who are trusted in the community to continually blast the news. Because
activists.
The activists, because most of the written stuff people are suspicious of. And some people can't get it, don't get it. Some can't read it, but most are suspicious of it. You know, who's distributing this and why? So I think direct communication in some fashion with all sectors of that community is the most effective way to do it.
Great. So it sounds like just really getting boots on the ground and physically getting the information out there, even if it doesn't involve the internet. Is that what I'm getting for both of you?
Yes.
Great. Well, thank you. So I'd like to expand this question a little bit more to, I guess, communities at large. And this will wrap up the section on misinformation. So either of you, feel free to comment on this. What is the role of the everyday individual in combating the issue of misinformation? And this can include, this is mainly, it seems like an issue that's prevalent on the internet. So, you know, if you go out into a neighborhood with a bullhorn and send a direct message, it might be hard to combat misinformation in that respect. But on the internet, there's a lot of false information going around about the vaccine. So how do we combat that? How do we get people the right information on internet platforms?
I think that some of the social media providers, I know Facebook has been censoring, like I call it censure, but they've been taking down posts that are inaccurate news, and I know that we saw that for the first time during the Trump administration, where they started taking out, like, he was saying things and it was inaccurate, and they started taking things down. I think that that'll help because they do a lot of monitoring on Facebook and social media sites. They do monitor what people put. At least I know they monitor what I put on there. I have lots of friends who are in Facebook jail right now. But you know, I do think that they do some monitoring and able to see what's on there. But I think the other thing is, if something isn't correct, I think they have a thing that they put on there now that that the content isn't correct, and they put like the line through around the content. But I think that, you know, for us, for our community, it's just letting them know what is correct. Like, so for me, for my page, for my Facebook page, like I said, I do an update around my COVID and around my family's battles with COVID, just so people could understand. But I put the correct information, because I think that we didn't put enough information about letting people know that if they've already had COVID, the wait time in order for them to take the vaccine. Like, if you have COVID, you can't take the vaccine today. If you've taken one of the antibodies, that you cannot take the vaccine today. If you have other chronic issues, you know what's going on with that, or if you're pregnant, like, to put out that information so that people know the correct information. And so when they go onto my page, they're getting the right information in real time. And then I also put up how long they should wait after, how long before they have um long before the antibodies work if they actually are taking the vaccination. Because I think a lot of people were going to get vaccinated and immediately, like, going out and putting themselves at risk because nobody told them that you were not, like, you don't have a immunity today. And they're like, "Oh, I'm good. I took the vaccine." And now I'm like looking at their pictures, and they're like, "Oh, I'm out here having lunch with my friends." And I'm like, "Did you just do this today? Was this an old post?" You know, and I'm like, "Okay, well, you know, you can't do that." So going in and putting the right information in, and I think it'll take, you know, all of us. I think that's where the individual comes in. So mine is an individual page, it's not a business page, but I do put the information, the correct information, on the Northeast Ohio Black Health Coalition page. But I put that on my page too, so that people know that if they're looking for something around COVID, that they can look on my page and get the right information. Um, so for me, that's, you know, that's the where the individual piece comes in. It's like somebody may be telling a lie, but on my page, I'm telling you the truth about it, so people can look on there and know that they got the right information that comes from a reputable source around the vaccine and around the testing. Because the other thing that we're getting now, and I don't know if Dr. Jackson, you know, talked about, but we have a lot of people in the early. So when I first started doing this work, some 27, almost 30 years ago, HIV, we would get people who would come in, put themselves at risk, come in and take a test. And then a month later, they would be back. And I'm like, "Why are you back here?" And they're like, "Oh, I was at risk again, so I came to take a test." So they were using the test, you know, instead of using protections. And so we see the same thing with COVID. is that people are going in every week, taking a COVID test, and they're like, I don't have COVID. So now everything that they did last week, now they're doing that plus one. So they're like, okay, well, I did that plus this and I still didn't get it. So now they go back, take a test, and they're like, okay, well, you don't have it yet. You don't have it. They go back and put themselves like, do you know, and eventually you're going to get the virus because you're putting yourself at risk. And so we have a lot of young people who won't take the vaccination because they keep going to get tests. And so the testing site has to change their message too, because the testing site has to say, look, you can't keep coming back here taking a test. You need to get the vaccine because the vaccine is going to do this, this, and this. So you can't keep putting yourself at risk and coming in to take a test. So we got all these people that are taking, so the number of tests that we've gotten have gone up and the number of vaccines that we were given are going down. And that's because young people are going to get tested, but they're not doing a vaccine. So there's a problem up here. So we need to make it plain to young people because their individual risk factors are their parents' risk factors, are their grandparents' risk factors, are their aunts and uncles' risk factors. Because while they out here doing dumb stuff, those are the people that are going to be harmed as a direct result of them not wanting to do the vaccine, but still do all the things that put you at risk. Like these kids are doing everything. They're at bars, they're at clubs, they're hanging out, they're not wearing masks, like they're not social distancing. Like for them, they're like, this is a joke. You know, they think that, oh, well, you know, COVID doesn't exist in their mind because they can go and keep taking a test. And nobody at the testing site is talking to them and saying, you know, this is what the test is, but this is what you need to do and this is why. And you know why I know what they're not telling you at the testing site? Is because I have taken the test because I tested positive for COVID. And so when I'm like, are you going to give me any other information? They're like, no. And I'm like, oh, okay. Like, okay, they don't give you any other information when you go to the testing site. And so we need to do something to make sure testing sites are helping individuals make the right.
Right. Dr. Jackson, would you like to comment on?
No, I have no added comment.
Okay. All right. Well,
I agree with everything you said, Yvonka.
All right. Well, thank you, Ms. Hall. There's some great insights. And yeah, it sounds like there's a lot we could do on the internet in terms of, you know, increasing the concentration of trustworthy information, but also getting rid of that the bad information. And also, you know, at testing sites, like we got to make sure people know what to do and, you know, are taking care of themselves, of course. So I'd like to move on to the next section now, if that's okay. And of course, you know, feel free to connect back to the points you've made earlier on. So the first two sections have sort of addressed specific issues, misinformation and mental health. But now I'd like to focus on institutional responsibilities and how institutions can help mitigate the issues mentioned so far. So Dr. Jackson, I'd like you to respond to this first question. I think it really relates directly to your extensive background in working with hospitals, which is a key institution in this discussion, of course. So Cleveland has some of the nation's best medical institutions in the country, for example, Cleveland Clinic. And so with 4 major hospital systems and numerous universities, but often reports of poor health outcomes, how do we combat this? How do we make sure that the partnerships created between hospitals and the communities, how do we make sure these partnerships are actually effective? Because it seems like there's a disconnect between these fantastic medical institutions, but they're not actually keeping some of these communities healthy. So how do we fix that?
Yeah, I think, let me start with what I think is currently a possibility, at least, and that is that the current leadership of population health or community health that exists at all the major hospitals, a leader in those categories, are very interested in communicating, coordinating their effort in the community. For years, we've had instances where the hospitals might be in, say, the Kinsman area, and 1 week, and the next week the next hospital system goes to Kinsman. The next week, the next hospital goes to Kinsman, each trying to position itself as the preferred place for care for the patient, as a marketing tool. Today, leadership in those institutions are talking to each other, planning together. I've always wanted to see, and I've yet to see, hospitals take responsibility for defined geographic areas. Maybe it's within a mile radius of their institution, or whatever, so that they can be responsible for the patient education, for provision of care, access to care, awareness of what's available, and so forth. That has not yet happened, but I can see that we're getting closer to the day where it might, because the hospitals are now more talking to each other than any time in my experience. I think that would be one great way to begin to tackle the terrible inequity in healthcare within the shadow of these institutions. That's one way. Throughout our time, though, most of the hospital systems have been so competitive that they have not been able to collaborate. That would be just my message, that the hospital leadership currently engaging in collaboration, take that to the next level.
Great. So increased collaboration, I think, is the key here.
Yeah. And cut out the redundancy. Quit going to the same area and forgetting about area. Go to area X, forget area Y. And the perinatal mortality in that area may be 4 or 5 times that of other areas.
Right. Also making sure we're, getting resources out to the right communities. That's a huge issue in this broader topic, of course. So
yes. Back in the 70s, we started, along with some case medical students, a health center in Glenville. It didn't last. We started along about the same time the federal qualified health centers were just beginning to emerge. We had one in Cleveland at that time, Huff Norwood on 55th near Superior. But we started a center, and the medical students canvassed the neighborhood within a mile radius, going door to door, taking blood pressure, tuberculosis skin tests, lead levels. And we found a lot of pathology. And we also found that people began to trust us and the medical students. But our problem then was we were not able to get funding. We had foundation funding initially. That disappeared sort of gradually over time. And providing care to a patient, getting a third of what you almost have to spend to provide the care was unsustainable. So we actually went out of business. But I think efforts like that still would be very, very useful. You're actually going door to door. The federally qualified health centers have been fabulous, but we need one more dimension to them. And that is getting out, knocking on the doors.
Right. And that all ties back to, how we spread trustworthy information out to these communities. So great insights.
And funding. I mean, if there's funding for that, that would do a lot more, I think, than the funding to the major hospitals, which then just invest in more and more elaborate equipment, trying to outdo the competitor. If we had a little more funding in that area, I think ambulatory centers could do more in their surrounding communities.
Right.
We need a session just on funding.
Yeah, right.
Yeah, we need a session on inequities around funding, around where COVID money went, around philanthropic dollars, like what goes on with philanthropic dollars, and why do we have foundations? Because people don't want to pay their fair share of taxes. So, for me, I think one of the things that we can address around hospitals is that hospitals need to take on an anti-racism agenda. When we look at the outcomes of African American patients at hospitals, we have to understand that the reason that we have the outcomes that we have is because of the things that are happening internally. And so we have to make sure that hospitals are looking at anti-racism measures, that they're adopting them across the board, whether it's UH, Metro, or Sisters of Charity, for any of those hospital systems, to make sure that they're looking at their care access from the top down and from the bottom up, and that everyone in those hospital systems have to be trained around anti-racism. That means that if it's the people in the cafeteria, the people who are in the bookstores, everybody that patients come in contact with need to be trained on anti-racism measures. And so our hospitals have to do something that they've never done before, and that is address the racism that they have from the front door to the bedroom. So we have so many people that are impacted so terribly that they leave out of these centers, um, and don't quite ever receive the care that they need in order for them to live. And we do know that. We know that on how African American women that coming in and presenting with a heart attack are treated, or African American men that are coming in with stroke symptoms. I remember going into the doctor with one of my uncles who's now deceased, who had a stroke. I went in to pick him up, and he came out, and his speech was slurred. And I said, "What are they diagnosing you with?" And he said, "Acute intoxication" was on his list. I took him right back in there, and I said, "I need you to give him TPA because my uncle's had a stroke. I need it right now. I need some doctors in here. Like, patients shouldn't have to come in the room with Yvonka Hall in order for them to get the services that they need." So we need to address what role racism plays in our hospital, in our care settings. We also need to look at cultural competence, because cultural competence is understanding how these human resources systems play. Like, do we get people from A to B? So in hospitals, they're like, yeah, we do a good job of getting people from A to B, but do you get them to Z? Are you able to get them all the way across the board to the things they need in order for them to have the best health outcome possible, right? The other thing is around cultural awareness. Are we able to make sure that they understand the population that they're seeking to serve? But for my agency, for the Northeast Ohio Black Health Coalition, the most important thing that we look at when we talk about institutional responsibilities, it is cultural proficiency. So proficiency is understanding all of the dynamics that play out on individuals as they're coming to see you. So if you have a person who has 4 children and they're trying to get in for a doctor's appointment, and they're on the bus and they're 5 minutes late, and because you're 5 minutes late, we're not going to see you today. We're going to see you next month. So next month you need to come. Well, that person is there because they have something that's going on today. And so they need to be seen today. And so telling them that you're going to give them an appointment next month when they just pulled 4 kids across town who somebody couldn't find their shoe, you know, somebody couldn't get the things that they needed. And so they're trying to get there as quickly as they can. So we need to change, how we're caring for people in order for them to get the best quality outcomes. So when we're talking about these institutional responsibilities, it definitely comes for me around addressing racism and addressing the structural racism that we see in our healthcare settings.
That's great.
In my experience, the one of the very direct ways to do that would be to have diversity of your medical staff, particularly nurses, physicians, as well as other staff. But the more diverse the medical and nursing staff are, the more likely you are to minimize the negative impact of racism on any particular patient. It does, to have minorities in the environment does something to the sensitivity of that environment. And absent it, that also does something very negative, I think, in that environment. So diversity in various ethnic groups, religious groups is essential to provide the least racist care possible.
Right, and that goes back to what Ms. Hall talked about with cultural competency, right? We We want people to be able to feel like their care providers have a sense that they understand them and understand their culture and understand where they're coming from. And of course, diversity can do that directly, but also with cultural competency, it seems like there is perhaps a lack of information among care providers, among people working in hospitals. They need to understand the backgrounds and the lives of the people they're actually working with. So the whole section on misinformation, it really goes both ways, doesn't it? It's of course getting information out to the public, but also getting information from the public and from different groups out to the care providers, and making sure hospitals and these institutions actually know how to care for the people that they're working for.
Mm-hmm. Yeah, no, I agree. But I think nothing is more instructive than having a diverse environment.
Of course.
I mean, so I think hospitals should work maximally to make sure they have color, various colors, as at many levels as possible, leadership on down.
Right.
Definitely. And that's not so. And you look at various leadership hospitals in Cleveland, at the top, you almost never see people of color, either brown, black.
At the top, in the middle, you see them in the kitchen and in the laundry room, and that's not fair.
No. So I think that's something that I can walk into a hospital and meet the leadership and know right away what you will find.
Seems like diversity then is the key.
It's key. It's key. And then for colleagues to be then comfortable enough to say, if you meet, a patient who's reluctant to do something and you suspect it may be because they don't trust you because of some racial issue, when you can comfortably go within your own group and have the resource needed for that patient, I think that creates an environment where everyone will begin to feel welcome and to get treated fairly as well.
Right.
Definitely. And people have a better outcome. Dr. Jackson,
Mm-hmm.
I mean, you've done such a wonderful job, in your service to the community as a physician. We need 10 times more like you. I think, that our community just, when we don't have leadership at the top that really understands what's going on, the dynamics that play across the board in the centers, and remember that I tell my story, and I tell the stories that have happened to me, like the most painful things, because of what I'm hoping is that sharing the things that hurt me the most will help people who are doing this work understand how much they hurt me. And because I'm able to articulate it and other people aren't, I went to visit my uncle, who I told you earlier, who had his arm amputated. I was sitting in his room. This was 2 weeks ago, sitting in his room. I'm sitting there messing around with my phone. And you have to sign in at the desk downstairs in any of the hospital settings now to go visit people. So you have to be on the books. Like, you can't just walk in. You got to be somebody that's listed in the patient chart. And a physician walked in the room. She looked at me and she said, "Who are you?" And I said, "Excuse me, who are you?" And she said, "I'm the doctor." And I said, "Well, I'm the niece." And she said, You're not listed anywhere." And I said, "Excuse me, you can't get in here without being listed anywhere." And she said, "How are you his niece? How who gets questioned on how they're somebody's family?" She said, "How are you his niece?" And my uncle, who's mentally ill, said, "This is my sister's kid." And she just looked at him, and my uncle looks just like me. Like, I look just like him. She said, he said, "This is my sister's kid." So this is the man who's here for schizophrenia, who's like, "What are you talking about? Like, she's related to me." And the doctor was so mean, that I had to, like, just go off. And she said, "Are you going to give me your name? And are you going to give me your phone number?" I said, "It's in your computer. I can't get up here without my name and my phone number in your computer." And she went out to the desk and called my grandmother's house, who's 90 years old, to verify that I am indeed my uncle's niece. How insulting. The other nurses and a physician heard her. She walked back into the room and said, I have your phone number and your name now because I called your grandmother. And I said, and if you call me, I'm going to sue you because I did not give you permission to have my phone number. Like nobody told you to put my number on your tablet. My number's in the computer. So the other doctor and a nurse came in the room and told her, go away. Came back and told, we are so sorry. We are so, like, we witnessed the whole entire thing. That should never have happened. And I'm looking at this woman like, I don't think you realize that you talked to the wrong woman today. Like, I just was so, like, when she said, who are you? I'm like, what? I'm like sitting there going, okay, well, I'm like in a t-shirt. Do I look like I like escaped from somewhere? Like, who am I? I'm his niece. And so my uncle just said, that's my niece. And so I think that we really have to do something. Because that should never have happened. Like Dr. Jackson, am I correct? That should never have happened.
It never should have happened. No, it really shouldn't have.
I was floored. I couldn't, like, for me, I couldn't quite get what was going on. Like, what the heck? Like, did I just walk into a whole nother time thing? Like, I walked in downstairs, I signed in at the desk like everybody else. They checked my name off, they checked my number, they sent me to the room, and now I'm sitting there and I'm having a physician say, well, who are you? You're not you, who are you? And then to go call my grandmother's house and say, there's a lady up here. And I guess she gave a description of me. And that's what ticked off her coworkers that made them come running. Like, there's a black girl in the room. And, we can't figure out who she is. And so my grandmother said, yeah, some lady called. And she said, yeah, does your granddaughter have like shoulder length hair? And my grandmother said, yeah. And she said, well, what's her name? And what's her phone number? And she came back and said, oh, I now have your name and your phone number. What do you need that for?
Yeah, one of the issues I think that I most commonly observed over the half century that I've been a physician is that cultural diversity emphasizes the diverse meaning of events, things, words in various populations. And the most powerful part of diversity to me is trying to get to understanding how this individual wants to be treated and coming at individuals with respect, no matter your differences, and trying to get from them as soon as you can how you want to be treated. For example, over the years, when patients or nurses or aides would address older Black patients by their first name, there's no worse insult in the Black community than to see that. It takes us back to the memories that we've heard from our ancestors about slavery and all of that. So it brings back a lot of negative images, and you sort of almost destroy your ability to really relate to me or me to relate to you. Whereas if you can quickly get to how would you like to be treated? For example, Mrs. Jones, may I call you Mrs. Jones, or what would you prefer I call you? When you do that, you immediately disarm a lot of other stuff. You can make other blunders, but you have shown me respect. And that gets you a long way down the line in my trust. I know you respect me, and you can get a lot from me that you can't get when you disrespect me. And to me, that's the biggest issue in interactions with patients.
Right. It seems like, diversity could really, just increasing diversity in these institutions could really help with that, because it's not only, having more color in the staff population, but also those people of color can share their experiences with the other, say,
Absolutely.
People who aren't of color, for example, and that could really create a lot more cultural competence, like Ms. Hall mentioned earlier on in these institutions. So,
yeah, but I think a lot of people, whites, for example, in relating to blacks, that there's as much distrust. I mean, when somebody white comes to me suggesting something other than what I consider respectful, there's a lot of history behind that. Similarly, I'm sure there are things I could do to show disrespect to my white patients and white colleagues as well. But when we have the mixture, you can get that. When I was in training, for example, some of my white fellow trainees, when they would have a black patient, who seemed not to want to accept that recommendation, they would come to me and say, Ed, would you go talk with this patient? They would tell me about their case, and I would go talk with them, and very often the patient would listen to me, because immediately when I go in the room, they say, oh, wow, somebody I can talk to. And if I also enter with respect for that patient, it made a lot of difference. So we did that, and I would do that in a white patient who didn't want a black doctor. I would say, you know, what I really want is a great care for you, and I don't want to care for you if you don't want me to. I mean, hell, I can do other things, but people want me to do it. So I would get a white colleague and ask them to go talk to this patient.
But I think too, the other thing, working in a hospital setting, because I worked in a hospital for 10 years, with physicians. I worked, on the floor. And so what would happen too is they would help each other out a lot. Like they could check each other more so than I could ever check them. Like
Yes.
the other one would say, look, don't do that. Like if you
Yeah.
walk in here with her, like they would tell each other. And so for me, it was, you know, the thing is that these two, they're colleagues. So they're able to say things to each other, too. And so for us, that we made it work because we were working at a community health center. And so when you're working in community health, you get the whole gamut of patients. You get people who are homeless, you get people who, you get marginalized communities all the time. And so when you have people who are, like want to complain about this person is smelly, whatever, and these doctors are saying, you know what, let me handle him, you do this one, or they would go up to the thing and say, okay, well, you handle this one, you handle that one.
Right.
Because they knew, that there were certain ways, or if you had patients who you knew preferred African American physicians, the people who see them all the time know, like they don't want anybody but an African American physician. So we're going to make sure that you see them, so that we won't have any problems here in this room, because we know what would happen if we sent doctors that patients didn't want into their rooms.
Yeah.
Like all hell would break off on the floor. And so for us, it was like we want to keep the floor peaceful. And so that the way to do that was to make sure that we had, that we worked together to make it work. And for our patients, they had the best outcomes, because for us, it was always making sure that at the end of the day, we didn't have no headaches, that
Right.
they didn't have any headaches, and that we didn't have any headaches. We wanted everybody to go home happy. And so for us, I don't see that in the systems today. Like they don't have the teams like we had. That was 20 years ago. Like they don't have the teams like we had, where we checked each other. We had our own checks and balances of each other in our departments. um and we miss out on a great deal, as a direct result of that. But yeah, we did some stuff then, and we enjoyed each other outside of our work hours, but in our work hours, we worked as a team to make it happen and to make our patients have the best outcomes. And I still see those patients in the community, and they're like, you used to work in social services. And I'm like, yeah. And they're like, I remember you. I remember you giving my kids coats. I remember you doing different stuff. And it's because we work to make sure that our patients, at the bottom line was making sure that our babies had a good outcome. And that our young people, that they were in school. A lot of them have become nurses and doctors, and they come back and they tell us, about their experience of being kids. They're with us, in the hospital setting, and how that changed their lives. And I think that that's what we all want to do at the end of the day, is change people's lives, make them have a better outcome, a better today for a greater tomorrow is what I say.
Mhm.
Absolutely. Thank you so much, both of you. So I'd like to kind of wrap up this section. We're running a little low on time, so I'd like to wrap up this section with this last question. And this relates directly to some of the disparities in healthcare that we see in Cleveland, but also relates to all places struggling with these inequalities. And so before I present the question, I'd like to share a statement made by the Ohio House Minority Leader, Amelia Sykes. And this is regarding the per capita based distribution of funds from the CARES Act, which both of you are familiar with, but this was a coronavirus relief act. And to provide some background information about the CARES Act, really just for the audience, I know you both are familiar with it. The CARES Act allocated federal funds for relief in response to the COVID-19 pandemic. The act was signed into law in March of 2020, just as the nation began slowing down the economy. And in the state of Ohio, nearly $650 million in funds were allocated to help fund local governments that had incurred costs due to the pandemic. Amelia Sykes stated, quote, "While these dollars are essential for our local governments, the CARES Act funds simply were not distributed fairly, with urban areas that have been hit hardest by the pandemic being left behind." So I'll open this final question up to any of you. What mechanisms would you like to see implemented to ensure that resources are distributed appropriately? I know it's a very, very broad question, but if you could just kind of outline some things we can do to make sure funds are being distributed more fairly.
Yvonka, let me
Sure.
kick that to you. Because
Okay. So the Northeast Ohio Black Health Coalition, when we found out that the city of Cleveland was going to receive $541 million as a direct result of the CARES Act, and that our illustrious leader wanted to use $372 million for policing, fire, and EMS, I thought, well, this is the CARES Act dollars. Like, these dollars should help to do equity in our community. Like, we cannot declare racism as a public health emergency and not use all of our dollars to address the equity issues that are disproportionately impacting our community. So we actually released a report called the African American Rescue Plan as a direct result of the CARES Act funding for the city of Cleveland that can be used anywhere in the country in our urban settings, on how we looked at where the dollars should go. We looked at the social determinants of health, and strategically looked at how those dollars could be used to change the outcomes for our communities, and to change the lives of young people in our communities for years to come. And so for us, that was very important. Um, Making sure that those dollars that we have are not a windfall. Those that $541 million is not a windfall for us to go use into whatever we thought was the current trend for the day. It's actually used. It should be used to address the issues that COVID caused. And so those issues are social issues. Those issues are those social determinants of health. We have to look at education, employment, housing, and health. We have to make sure that all of our children have access to the Wi-Fi, to the World Wide Web, and not only just to the World Wide Web, but if they only have like limited Wi-Fi speed, then that means everybody in the house. If you have 5 kids at the house and everybody has a computer, then if you use the Wi-Fi access speeds that they have now, everybody can't use it. So which kid are you going to say can use the computer today? Okay, well, everybody can't get on today. So looking at those issues, looking at employment opportunities between our 14 to 24-year-olds, and saying we can use $6 million for the summer to employ every single child between 14 and 24. The end result of employing every single young person in the city of Cleveland, making sure that they have every single, not 100, but making sure that every single child between age 14 and 24 in the city of Cleveland has a job. That means security. That means less violence. That means, less cost to the hospital or for the ambulance, because now people have dollars that they're able to use to help uplift their homes. Using those dollars in a way to help change the dynamics in the community. The other thing was around menthol cessation programs, having those programs in place, making Cleveland a no menthol zone where we're not selling mentholated products in our communities at all, because African Americans, 9 out of 10 that are smoking mentholated products. And then if they're using those mentholated products because they are smokers, their risk of COVID is even high. So part of the CARES Act should be to address the issues around COVID, and that is a big issue in our urban setting around COVID, is the number of smokers that we have, and what they're smoking. And a lot of them are smoking mentholated products, and so we looked at it that way. But what I can say, as a direct result of this African American Rescue Plan, is that other cities across the country have looked at our plan and said, "Hey, we want to be able to use this for our city." Um, and I think that it can help change the dynamics of the city, and like I said, for years to come, and help change the outcomes for a lot of our young people who are actually struggling, helping with housing around our lead issue that we face in the city of Cleveland. So using those dollars strategically to address the issues that we saw the glaring need for around COVID. And so for us, those things were more so important than anything.
Great, thank you. And Dr. Jackson, if you could comment, please.
Well, no, the only comment I've made is we haven't, today at least, talked about jobs and the fundamental value of being able to get a job and provide resources for your family and self-esteem for yourself. So I think a very important issue, at least for the urban community, is jobs.
Absolutely.
I agree 1,000%, Dr. Jackson. That's why, that was one of our main things on there, that education, employment, housing, and health, like making sure that we had employment opportunities, because employment opportunities are the things that set your community aside from anything else. The reason why our suburban areas are safe is because people are working. The reason why we have so much crime and despair in our urban settings is because people don't have employment. And then people who are working a lot of jobs and making a little bit of money. So we need to pay people a fair wage, one. And then we need to make sure that we're doing everything with our resources as possible to make sure that our young minds are not idle. And if that means providing them with an opportunity to let them know that people work, like this is what work looks like. That will change their lives. I've been working since I was 14 years old. And so I know what work looks like. My work day starts early and it ends late. But I love what I do, and I'm able to create what I do. Like, this is, the Northeast Ohio Black Health Coalition was a brainchild that was sent to me. And so, I'm able to do a lot of great work in the community. And so I want young people to have those same opportunities, and they can't have those opportunities unless we give it to them. We have to, my first job was working at a community park, clean it up in the summer. I would go walk up to Carews Park, clean up the park, have activities available for the kids. That taught me the value of work. Who did I work with? I worked with college students, and I was in high school. So, it was like, I want to go to college. I want to do what they did. They go to college. I want to go to college too. What does college mean? And it changed my life, and so we want to change the lives of young people. And we can't change the lives of young people by putting money into policing. We can't change the lives of young people by militarizing our police districts. That is not changing the lives of our communities. And the only way we can change our lives of the community is to make sure that we're addressing the issues that are disproportionately impacting our communities the most. And then I know that there was a report that came out in 2002. It was called Racism in Medicine, the Slave Health Deficit, which was the National Medical Association. And they put it this way. They said, to eliminate persistent race-based disparities, the U.S. must implement dramatic changes in policies that hide the structure, functioning, and financing of healthcare systems, and must direct efforts to produce a system in the workforce that is culturally competent in dealing with African African Americans. It says that racism in medicine has operated at institutional, intellectual, policy, and personal levels, and it is deeply ingrained in the United States and the fabric of the US. And so we know that racism is here. We know that racism is in a lot of the things that we do. And so when we're talking about how do we use those dollars, we cannot use those dollars that can be meant to change our communities. In order for us to continue pushing dollars into racist structures that have not done our communities well. And so in order for us to lift our communities, we have to use those dollars wisely. Those dollars can really, really change a lot of people's lives.
Absolutely. Thank you both. And Ms. Hall, I just wanted to ask, I think some people are curious to see the African American Rescue Plan. They want to read through it and look up on it a little bit. Do you know where they can access like maybe an online document or any information about the rescue plan?
I know if they type in African American Rescue Plan or Northeast Ohio Black Health Coalition, it should pop up.
Okay.
And if not, I'll make sure that you get it.
Great. Thank you. Thank you so much. So if you're both done commenting on the last question about the distribution of funds, that was really the last question I had. However, if it's okay with you, that there is one question in the chat, it looks like, from someone in the audience. So I was wondering if you could touch on it. And I just reading the question, I think it's something we've already covered, but maybe if you could reiterate the main points made earlier, right, that would be great. So the question is, does the stigma surrounding mental health treatment look different in the African American community than in the general population? And I think we've talked a lot about this, probably not enough, but if you could just reiterate the main points around that question, please, that would be great.
Would you repeat that question?
Yeah, sorry. So the question is, does the stigma surrounding mental health treatment look different in the African American community than the general population?
I don't know any data that speaks directly to that, but certainly the stigma is a major problem. But again, I would suggest that the major problem in the minority community is access to jobs, access to education. I think those are the more fundamental issues. And then you have a lot of other issues like equity with police. But the key is jobs and comparable pay for work done. I think if we could fundamentally do that, we would go a long way in eradicating a lot of the health disparities and negative impact of policing and other things in our society that's comes from our history as a country.
Yeah, I definitely agree. You know, for me, I actually have a pillow that I made that says that the cure for Black trauma is justice.
Okay, right.
And so, and so that's the name of my book. The cure for Black trauma is justice. I am tired of being sick and tired is the name of my book. But when we talk about African Americans and mental health, we have to know that African Americans are less likely to receive accurate diagnosis than their Caucasian counterparts that have mental health. And so we already start off with a deficit there, is because we're not being diagnosed in the way that we should. But we definitely need to concentrate on some of the other things around trauma. And that's around lack of jobs, lack of educational opportunities, not being paid a fair wage. Like all of those things play on people's psyche year after year after year. And so people who are already we're like a rubber band. And so most of us are able to bounce back, but there are some of us that can't. And it's because people are carrying the weight of the world on their shoulders. And it's because of, the role of, what racism has done to the African American community. And again, I say we are the most studied, but the least compensated community in the United States. And so we have to make sure that we're addressing the issues that disproportionately impact us. We can't, African Americans cannot cure racism because that is not something we created. And so it takes to our white allies in order for them to address the historical trauma that has been caused by racism in the African American community. And whether that's talking about the impact on mental health and what it does, or around policing, or around jobs, or around education, or around housing, um, you know, it's going to take our white allies to help change that. We can't do this by ourselves.
Absolutely. Well, thank you. Hopefully that answered that question for that person. I think it did. So is there anything else you'd like to say? I know we just had a discussion on a lot of broad topics here, but is there anything else you'd like to say to the audience before we sort of conclude this panel?
I would say that students have a lot of power, a lot more power than you recognize at this level of your training. And you have a lot of power in assuring that environments you're in are more equitable. And a lot of that assessment can be made by simply looking and seeing the absence of diversity at certain levels of the institution, and demanding more justice and equity wherever you are. One of the sort of stories I like to think about a lot, and maybe share with you, take a minute, is back in medical school, David Satcher, who went on to become Surgeon General of the United States, graduated from Case Med School in 1970 with his MD, PhD. But when David was a senior student taking gynecology, the professor used to have, there was a ward, a section in the clinics that was for staff patients, which was a buzzword for Black patients and poor patients. He would line 10 students up, have a patient in stirrups, and each one would go and do a pelvic. And David Satcher, the only Black student in that group, refused to do it and left med school. He thought that he had lost his opportunity to get his MD and his PhD. He had put in 6 years already, and he was already in the Honor Society. But he was defenseless in fighting the system. But his classmates, who were all white in his group, went to the dean and demanded that he be reinstated, that he be apologized to, and that the faculty who put him in that situation be reprimanded. And you know what happened? Precisely what the students demanded. So there's a lot of power with our white brothers and sisters to advocate on our behalf, just like we can advocate on your behalf. So I think that's when you really get a lot. So I wanted you to understand that through my eyes, you as students have a lot of power. And don't forget that.
Absolutely. Well, it's very inspirational. Thank you for sharing that. And Ms. Hall, would you like to, I guess, finish off the panel with any last comments?
Oh, I thought that was excellent. That whole fighting spirit. And I use it for the Northeast Ohio Black Health Coalition, because my organization is new, relatively new. And so when we talk about not being able to receive funding, because I am willing to speak out about the issues that matter to my community the most, I think that that's wrong. I think that my organization should be funded just like any other social justice organization that's working to address the issues in the larger community. But because I'm addressing issues that are very sensitive to people who, when they want them to be sensitive to them, I think that it's wrong. That we have to ask for people to give us donations in order for us to do the work. Last year we reached, like I said, we sent out 70,000 meals, from my house. We also, on our conference, we have 48,000 participants for last year's conference. Like, we do the work, and so it's not that African American organizations don't do the work. It's that when it comes time for funding, to cross our path. Is it doesn't cross our path. And so for students to see that and say, look, we need to make sure that these organizations are funded. We have all of these dollars coming from, like I said, from COVID. And when we look at, the amount of dollars that's going to African American communities, if I'm telling you that, it costs us $10,000 a month to buy food, and then I have a foundation that says, well, we're only going to give you $20,000 for the whole year. Who doesn't get fed? So when I sent out food on Sunday, I had to cut 60 families out. So we only were able to feed 30 families because we just didn't have the money to feed everybody. And so for me, that's wrong, because that's not a decision that the Northeast Ohio Black Health Coalition makes. It's something that a foundation that has the money that people have given them in COVID relief funds to provide, and they don't. And so for us, we need to make sure that our allies are willing to push that and say, why aren't the organizations that are doing the work receiving the funding in the hospital settings? You also need to say, where are the people who, besides housekeeping, where are the people who are medical professionals that can help me in this work to make my journey a little less hard? The other thing is being culturally competent and culturally proficient when you're dealing with patients, and making sure that when you come into a patient's room that you don't go onto the computer first. Like, we have a medical system that now says computers first, patient last. And that's not fair. That's not fair to patients who don't look at computers first and patients last. They look at quality care first, and you do your home. And so we have to change our mindset. And when we change our mindset, we'll change our world. But we have to do it together.
Absolutely. Well, thank you both so much. This has been a terrific panel. So I'd like to, on behalf of UHA Cleveland, I want to thank the panelists once again for their time and insights. These are important and relevant issues. This is a very important conversation to have. And of course, I think this has inspired a lot of other conversations too, especially in light of the current COVID-19 pandemic. So we'd like to offer our sincere appreciation for the extensive work that you both have done in aiding health disparities and advancing social justice over the course of your careers. Thank you. And this panel was recorded, and it'll be disseminated widely in order to generate greater awareness. And again, if you're interested in checking out UHA Cleveland and its other initiatives, please check out our website, which is in the Zoom chat. And thank you, everyone. So that concludes our panel. Is there anything else? Any last questions before we disperse?
It's been a joy to see my old colleague, not old, she's not old, but my longtime colleague.
I've enjoyed being on the panel with you, Dr. Jackson. I think you are the consummate professional.
It's been a joy for me to meet with you guys and talk with you guys and to get to know you.
Thank you, Reese.
Oh, thank you, guys. This has been terrific. I've learned so much, and I hope we can continue to have these kind of conversations in the future.
Thanks.
All right. Well, thank you both. Have a nice day.
You're welcome. Bye-bye now. Bye-bye.
Bye.